Chinese New Year festivities. I think for those of you who are celebrating, and focuses on health and wellness. And for the past few episodes, we've been actually talking wellness. And for the past few episodes, we've been actually talking about various types of cancer and its management. And today we're going to talk about cancer and its management. And today we're going to talk about a silent yet rising cancer, pancreatic cancer. I think many of us don't even know where the pancreas is, let alone pancreatic cancer, where the pancreas is, let alone pancreatic cancer. If you have cancer or the management of it, remember to put your questions in now so we can pick them up at the end of the show. Like I said, for the new ones to the show, we take questions towards the end of the show, so we want to hear from you. We love to take questions. And also, as there's little understanding about pancreatic cancer, we want people to know more about it. So share this with your friends, with your family. Click the share button on YouTube or on Facebook, or even just share the link, all right? So we're waiting for you to share. Please do so now. Now, let's talk about this silent yet rising cancer, which is pancreatic cancer. Like I mentioned earlier, little is known about pancreatic cancer here in Malaysia. And pancreatic cancer is usually detected late, resulting in poor survival outcomes. And this is usually because of the lack of information of it and sometimes misunderstanding about pancreatic cancer. And this results in a lot of people presenting in later stages. So if you have questions about pancreatic cancer or just about cancer, remember to start putting in them right now so you can take them at the end of the session. And more importantly, share this so we can get people knowing, understanding, and just basically anything about pancreatic cancer, because not a lot of people even know where the pancreas is. I'm saying this as a fact because I've asked people whether they know about pancreatic cancer, and they always give me a puzzled look. They don't even know where the pancreas is located. I mean, except for those of you who study medicine, or if you're interested in it, or if it plagues you. So in recent years, however, there have been a lot of recent developments when it comes to research on pancreatic cancer, as well as the treatment of it. And that's why we're here. We're here to find out more about how to manage and treat pancreatic cancer and all these new recent developments. And with me here today, we have Dr. Jennifer Leong, who is a clinical oncologist at Curie Oncology with a special interest in the gastrointestinal tract. Thank you so much for joining us once again.
Thank you.
And we have Dr. Pan Nop, who is the head of primary care as well as emergency and wellness services at Sanjio Center. Thank you so much for joining us as well, Dr. Pan. So let's jump right into the questions that we have. I'll start off with Dr. Pan. What's the prevalence of pancreatic cancer here in Malaysia? We need to set the ground rules. We want to know how many people actually get pancreatic cancer in Malaysia.
Okay, so as we know, in Malaysia, pancreatic cancer is not the most common cancer. In fact, for every 100 patients who are diagnosed with cancer, 3 of them probably suffers from pancreatic cancer. And there is a reason to why the incident rate of pancreatic cancer is lower. In fact, it's ranked 14 among the most common cancer in Malaysia. The first, of course, as we know it, is breast cancer, followed by colorectal cancer, and then your lung cancer. But as Mei Sze mentioned earlier, pancreatic cancer, although the incidence rate is low, it is a very deadly cancer with a very low 5-year survival rate of 5 to 10%. This means that out of 100 patients diagnosed with pancreatic cancer, we expect only 5 to 10 patients manage to survive beyond the 5 years period.
Yeah. And that's because they present at later stages, right?
Yes.
Okay.
To catch the cancer early at stage 1 or stage 2, whereas more than 80% usually present to us too late at stage 3 and when stage 4, when the cancer is already metastasized.
Thanks, Dr. Pan. So, Dr. Jensen, talking about the symptoms, following up with Dr. Pan's statement, what are these early symptoms of pancreatic cancer that we should know of and that normally patients encounter?
Yeah. So, first of all, thanks for having me back again. So speaking about the symptoms of pancreatic cancers, but before we actually talk about the symptoms, like Mei Sze pointed out, that some people, audience out there, they're asking what pancreas is all about. So I wanted to describe in a very general term. So pancreas is actually one of the vital organs in our body, which is in the abdomen itself, and it's just lying just right behind the stomach, and consider it's like a hero that helps in it serves for two purposes. These organs. So number one is for the digestion, and second is our blood sugar control. So for the digestive part, what it does is that it secretes juices. So the juices helps to break down the food that we take in, and allows for our body to absorb the nutrients and all that. And consider that pancreas is like your super blenders in the kitchen that helps to break down all this so that your body can absorb the nutrients. Second part of the pancreas is the one that helps control your sugar. So it has this part of the endocrine hormones that helps to secrete, that regulates the sugar. When the sugar goes too high or the sugar goes low, then your insulin, which is the one that is secreted, helps to regulate this. So consider that this part of the blood sugar regulator is like a thermostat in your bodies that helps to check your sugars in balance. So when we talk about pancreas cancer today, I thought about the most common is the one that secrete the juices. Those are the one that is the most predominant and the most common type among the pancreatic cancers. So speaking about the question earlier about the symptoms, so pancreatic cancer's symptoms remains very vague to start off with. A lot of time it can be misinterpret as some other conditions. So in general, to talk about symptoms, I would say the most common would be having abdominal pain, which sometimes it can be gradually become more persistent. As some patients that comes to see me, they actually complain about pains that goes all the way to the back. There are cases whereby patients actually present with yellowish of the skin. We call it as a jaundice. So jaundice happens is when the growth is getting bigger and it blocks the passage whereby your body becomes yellow. Then of course there are cases whereby you have patients that somehow have unexplained weight loss despite trying to gain weight. And some other things will be feeling fatigue, easily get tired. And there are cases whereby at quite a younger age, they already diagnosed with having poor sugar control. So sometimes one of the indicators is to look into is that there's someone that is around the 50s, where it's already suddenly you diagnosed with diabetes and all that. Doctors may want to check and see whether this is because of there's interruptions in terms of the sugar control by the pancreas. So the others will be your bowel movements, if your stools and all that have changed in terms of colors and all that. So those are also the signs and symptoms that that tells you whether you should get medical consultations further to get it checked. Yeah.
So these are not normal symptoms. I mean, a lot of us think they are normal, so we should actually look out for them, like what Dr. Jensen mentioned. So this are symptoms of pancreatic cancer. So thanks Dr. Jensen. Now back to you, Dr. Pan. As the head of primary care emergency services and wellness, how do you see your role taking part in addressing common cancers in Malaysia, and in this case, pancreatic cancer?
Okay, so with the more common cancer out there, there is a standard of care. There is actually a gold standard, a recommended screening test that we can done. But for pancreatic cancer, it's a bit to a higher risk of developing the similar cancer in the future. And of course, when we screen for them, we are also actively looking for any genetic mutations. There are some known genetic mutations such as the Lynch syndrome or even BRCA1 or BRCA2 that predispose someone to develop pancreatic cancer. It's quite surprising when we talk about, for example, BRCA1 or BRCA2, because we tend to associate BRCA with breast cancer.
Yeah.
Yes. But in the pool of pancreatic cancer patients who have been diagnosed, they found out that actually 8% of them carry this BRCA gene. So if anyone in the family is diagnosed, is being tested through genetic screening, and they are found to have this BRCA gene, then we should have a higher suspicion, a higher index of suspicion for this patient, and we start to look out for pancreatic cancer. Start the screening early. Yes. And then secondly, we should educate the patient as well regarding the risk factors. And when we talk about risk factors, we talk about those modifiable and non-modifiable risk factors. Non-modifiable risk factors are things that we cannot control. For example, as we age, there tend to be cell mutation, and the risk of developing pancreatic cancer will become higher. The second one is, of course, is our genetic. If our genetic predisposition is such, then there's nothing much that we can do besides screening it early. But what I would like to emphasize here are those modifiable risk factors. These risk factors, the first one, the most common one is, of course, smoking. Smoking, cigarettes or vaping, it contains carcinogen, so it causes our cells to mutate as well. That can develop into pancreatic cancer. But the good news here is, for any smokers out there, if you stop smoking for more than 20 years, your risk will normalize to those of to that of a normal person. Yeah. So there is a very strong incentive for patients to stop smoking. Then the second one, fortunately, is the excessive consumption of alcohol. So alcohol itself, again, is a form of carcinogen. So it can cause us to have pancreatic cancer. But what I'm talking about here is excessive drinking. So the NICE guideline in the UK allows us to drink, but only a maximum of 14 units of alcohol per week. And it's not in one day, spread it over 3 days. Yeah. So it's important to note this risk factor as well. Then the third risk factor, which is modifiable, which we can, with effort, change over time, is obesity. They have identified that those individuals with BMI more than 30 kilogram per meter squared, for example, are at higher risk of developing pancreatic cancer. And then what primary care service can do as well, I feel, from our part, is to constantly update ourselves on the latest treatment, in the field of oncology, particularly in the treatment for pancreatic cancer. And I do understand that there are some breakthrough coming in terms of immunotherapy, or even the form of mRNA vaccine for pancreatic cancer patients as well. And when I talk about pancreatic cancer, there's no point in just describing the mortality and all. When we talk about it, we want to screen it early, because we know pancreatic cancer is deadly simply because it presents to us too late, stage 3, stage 4, and when the cancer becomes not resectable, that means it can't be surgically removed. The prognosis, the outcome for the patient is usually poor. So the role of primary care, or even in the wellness center, is to implement this available screening test. Yes. Besides taking the basic history, performing a physical examination on the patient, once we have a suspicion that this could be pancreatic cancer, we would send the patient for further investigation. We talk about transabdominal ultrasound, but sometimes that is not very sensitive. It can only detect a mass that is more than 2 cm. So we have other more advanced imaging methods. For example, the endoscopic ultrasound, EUS. We can perform ERCP. We can do a contrast CT. We can do an MRI scan, which is very sensitive in picking up any mass as well. Yes. So there are some breakthrough in terms of screening for pancreatic cancer, although this is not available, easily available yet, simply because perhaps the cost is still slightly higher, is in the field of ctDNA. For example, spot mass. They provide a test which can detect any circulating cancer cells in the body. So instead of waiting for the pancreatic cancer to progress into a later stage when it's huge enough or when it's causing symptoms in our body, you are now able to detect any circulating cancer cell in the body at an earlier stage.
That's interesting. So that's related to, I think that one is very advanced type of screening as well. I think a lot of people would like to find out more. So we can save that for the questions that you may have, but I would like to kind of about the modifiable symptoms. The modifiable things that we can do to prevent the risk, which is no smoking or vaping, no excessive drinking of alcohol, and obesity. So start exercising and eat well. I think these are the three main important things I actually captured from Dr. Pan. I know it sounds so simple, but it actually isn't for a lot of people. So thank you so much for sharing the modifiable and non-modifiable risks. So following up from what Dr. Pan mentioned, Dr. Jensen, as an oncologist, how do you manage pancreatic cancer in your patients? Because we've discussed, most of them present at later stages.
Yeah. So speaking from my day-to-day clinical practice, so I always, when it comes to, I encounter patient that is diagnosed with pancreas cancers, I always remember this figure, 20, 40, 40. Just like Dr. Pan has initially pointed out. About 20% of patients are actually presented at a much earlier stage. So these are the type of patients that we are looking at surgery as the curative intent to get to aim for cure. Then you have the other 40%, which is borderline. We call it as some surgeons who initially have already saw this patient. They say potentially operable or resectable. Then these are the cases which things can get a little more complicated, I would say. Then the other 40% is the one that is already being assessed by the surgeons, and is deemed to be not operable or unresectable. These are the much more advanced cases. So 3 groups of patients. So the one that commonly encountered knocking at my door will be those at the potentially resectable or the one at a much later stage. So these two group of patients, I would say, is rather more challenging to manage. So the common things that when they first come to my room will be that, I will check on practically a few important things. Number one will be, is the patient in pain? Yeah. Second, is the patient is yellow, jaundice? Because these two things needs to be addressed first. Yeah. So otherwise, then in terms of treatments that needs to be discussed, it will become a hassle because patients are not feel comfortable. You have not solved the acute problem as yet. Then it's very difficult to initiate the treatments. So that's one. So as I mentioned, for the much earlier stage, then you have surgeons who have already done a surgery for the patient. Then this patient will actually come over to see the oncologist. Is actually to talk about the curative treatment, the chemotherapy. But for those with a much more, the 40% that is potentially, these are the cases whereby I always emphasize on having a multidisciplinary field doctors that is involved in this management to come together to have a discussion how best we can manage this patient, because we want to aim for the best treatment for this group of patients. Then the remaining 40% is the one that predominantly would be, the oncologist's purview, whereby doctors will have to discuss about the treatments here. So the treatments here, it varies from chemotherapy to doing some molecular studies, which will help the doctors in terms of what to be offered next. Yeah.
Okay. So in terms of management, you would say that you will categorize them into the types of staging that first, and then after that followed by the types of treatment.
Yeah.
Okay.
In general, that will be the how it goes, but it really comes down to you need to have a proper scans being done.
Yeah.
You need to have the staging is done accurately. You need to have someone that is familiar with this in this field in terms of surgery, that knows when is considered this is potentially operable or this is upfront surgery is can be done. So you need to have geneticists, molecular geneticists that actually look into if the molecular studies is being done upfront. So you have a few doctors that needs to come on board and to have a group discussions on that. So the staging itself, in general, yes, this is how you manage, but in reality, you have those that is not so clear cut. This is the one that you really have to go through properly and find the best treatment option for the patient.
So many times, I think for pancreatic cancer, in terms specifically for pancreatic cancer, a lot of people don't even know where to begin. So it's good that we are discussing this, that, we talk about the symptoms and how to actually kind of detect all these, like such as for the radiology, the CT scans, the MRI, like you mentioned, Dr. Pan, molecular geneticists is also involved. So these are actually good notes to and pointers for us. And then I don't like to ask this question, but I mean, what is the prognosis usually like for someone diagnosed with pancreatic cancer?
Yeah, so I think the prognosis here, you really need to look into the stage of the disease. Okay, so when we talk about prognosis, generally we look at the earlier the better.
Yeah.
So for early stages where surgery upfront is the curative way to go, then we are looking at higher chances of 5 years survival. Now, the moment when you have a tumor that is grown larger, but still confined within the pancreas, and if, let's say, the tumor has also involved the regional, adjacent structures like the nodes and all that, then the survival for the 5-year survival actually comes down further. And of course, like Dr. Pan explained earlier, the 5-year survival for those with the advanced stage is actually very low. So it's a challenging disease to treat, but all hopes are not lost. I think we are making lots of improvement in terms of advancement in the treatment for this. And I believe that, whatever the statistic in terms of survivals that we spoke earlier, that is when you look into one big group of patients that diagnosed. But we can't really tell in terms of individual. So some patients, they probably have a much better in terms of figure compared to those another person that may not be. Yeah, so that would be the general when you talk about 5 years survival.
Okay, thanks, Dr. Jensen. Dr. Pan, my last question for you is, as you are in primary care and emergency services, how do you foster close collaboration to ensure effective cancer patient care, and in this case, pancreatic cancer, between you and the oncologists?
All right. So how we work in St. John, for example, the emergency department or in the primary care setting, the first thing first is to have a high index of suspicion. There are a few things that we pick up because pancreatic cancer, and as I mentioned earlier, the incident rate is low. So it's not at the top of everyone's mind. Yeah. So there are some research, for example, that I would like to share. 1 in every 100 patients that are diagnosed with diabetes, type 2 diabetes, usually at the older stage, more than 50 years old, 1 out of 100, when we screen them, they actually have pancreatic cancer. Yes. So first of all, having a high index of suspicion is very important so that we can pick up all these cases early, go for screening, go for whatever investigations that are necessary, followed by a very prompt referral to oncologists. Yes. Most of the time, it could be a gastroenterologist or to a hepatobiliary surgeon as well, before the patients are being referred to oncologists. So this is where there is an advantage when the hospitals or the emergency department, most of the time they are using these electronic health record systems. So patients who are already quite distressed, hearing the news that they possibly could have pancreatic cancer, don't have to keep repeating themselves.
Yeah.
Yes. So the first time they are being seen in the emergency department, we log down the signs and symptoms, their presentation, followed by, they have to be seen by a surgeon probably. Surgeon probably just have to look at the electronic health record system, ask them, ascertain a few more questions, and then perhaps we can continue this multidisciplinary care to the oncologist. So it provides quite a seamless experience to a very difficult situation. And then the second part, I think as an emergency doctor, is to train my staff and even myself, to keep abreast of all the development in terms of identifying signs or symptoms for pancreatic cancer, and keep updating ourselves every year on how we manage complications, for example, of patients that come to our emergency department with pancreatic cancer. So most of the pancreatic cancer patients, if they are presented late, they tend to develop some severe complications. One of them, such as ascites, which is the collection of fluid in the abdomen, which can be very uncomfortable and painful. So there are certain procedures that we can do to drain out the fluid as well. As Dr. Jensen mentioned earlier, when a patient entered his clinic, his first priority is not to know what stage is this, how should I treat. The first thing we do is to make sure that the patient is comfortable. We alleviate any discomfort. Yes. So if the patient comes to emergency with ascites, we drain it. If the patient comes to the emergency in severe pain, then we'll be providing some strong analgesic pain management to help to reduce the pain as well. And I think at this point it's worth mentioning that we should provide support for the patient as well who are suffering through the disease. So there are certain organizations that we can seek help from to get support. For example, the National Cancer Society of Malaysia, MAGNA, or even Hospice Malaysia. So they provide valuable resources. When we are lost, when the consultation is long and tedious, they are already quite stressed. So when they return home, if they have any further follow-up questions, some personal or emotional support they would like to seek, they can seek help from this organization. Yes.
Thanks a lot, Dr. Pan. I mean, you guys know I'm the ambassador for the National Cancer Society of Malaysia. So you can call their hotline if you need emotional or any types of support they can provide for you. So if you have any questions, this is just a general hotline that you can use. But for the rest of you who are tuning in now, remember to start putting in your questions, because I have one last question and then we're opening the floor to questions. We want to hear from you. If you have any questions about what we've discussed today, please put them in now. We also have, like I said, Dr. Pan is the head of primary care and emergency services. So anything related to that, you can also ask. And of course, pancreatic cancer. So my last question is for Dr. Jensen. Are there any key messages that you'd like to convey to the audience before we move on to the questions from the audience?
Yes, Ms. Of course. I think the key messages for pancreatic cancers is that, like as what we have mentioned earlier, it's a pretty subtle symptoms that you can actually, knowing that whether you have or not. So I think the awareness here is the most crucial thing.
Yes.
So
I agree.
Getting to know yourself if you are not feeling well based on the symptoms that I have mentioned earlier or Dr. Pan earlier and all that, you should always, get yourself checked. And more importantly, if you have family that has also been diagnosed with, for example, like the genetic disorders like what Dr. Pan mentioned, BRCA, and if you have family history, has someone that also, loved one also being diagnosed with pancreatic cancers, you should always, get for the opinions from the doctors, from the health professionals. So that's number one. Second is that, like I mentioned, in terms of the treatment for pancreatic cancers, so you have those that comes in a group that, you requires a few, professional doctors to actually manage it. So a multidisciplinary sort of management is actually essential. So this is something that, should always get consultations, not just from the surgeons alone, but also from the oncologists, as well as other involved professional doctors that comes in management of pancreatic cancers. Number three, I think it will be one of the important things will be advancement in the clinical trials. So clinical trials allows you to, get the cutting edge technologies.
I agree with this.
And new targeted treatments that is potentially able to, deal with these pancreatic cancers. So never shut yourself down by just knowing that, oh, this is a clinical trial, I should not be, listening to it. Always have an open mind, have a listen to it, Then of course, the third thing will be that personalized treatments. So nowadays, when we talk about any of the cancers, right, we always look into this called molecular testings and all that, and genetic testing. Because these molecular studies and genetic testing actually opens up of lots of other potential targeted treatments, which previously we don't know.
Yeah.
But as the time goes by with the advancement in the health, in medicines, right, now we started to get to know more and more about these particular mutations that is possible present from the NGS studies and all that, the next generation sequencing molecular studies. So, and with this personalized treatment, then we talk about how we can integrate that to make it more personalized to each and every patient, because each and every patient's needs are different.
Yeah.
So we cannot expect the same treatment is going to apply to everybody. No, that's not true. Yeah. So of course, and last but not least is that, I think all hopes are not lost. Always have, keep yourself updated with the latest advancement. Just like, when you're driving back to work, you listen to podcasts, things like this, this kind of awareness talk and all that. It's also very important because it gets you to learn something, on day by day, that, health is part of something that is essential. It needs, you need to learn about it.
Health is wealth.
Yes,
and
correct.
I think talking about personalized treatment and talking about genetic testing, actually our next episode, we're going to deep dive into that. So please join us for the next session if you have burning questions or you just want to know about genetic testing or molecular testing. So that aside, we are going to take questions from the audience now. I think today we have tons of questions. I'm going to try to summarize some of the questions. Dr. Jensen, I think I'll combine these two questions. I think people want to know about CA19-9. Catherine mentioned, is it elevated in people with early pancreatic cancer? And also their cholesterol level.
Yeah, so good question. So I would like to address first and foremost the tumor markers. So the so-called the CA19-9. So I think in the day-to-day practice of Dr. Pang, when they talk about health screenings, they do take tumor markers along the way as part of the screening tools. Now, in some cases, yes, the CA19-9 is not really a very specific to pancreas, in the sense that if it's raised, it may not necessarily mean, it depends on how high if it's positive. So for someone that is chronic alcohol consumptions on a daily basis, you also suffer from this so-called the chronic pancreatitis, inflammations of the pancreas. Then you also may have a little bit, elevations in the CA19-9. But there are cases whereby that, the markers never raised, but they do have the symptoms. So at the end, you cannot just rely on the tumor markers as the only tools. You still need to get the doctors to be consulted, to get to know the other symptoms that comes along, like what we have mentioned earlier. So that's this first one. I think the second one would be the
cholesterol level.
Cholesterol. So as I mentioned that, pancreatic cancers predominantly from those pancreas, part of the organ of the pancreas that secrete the juices and all that. So part of this enzymes that is being secreted, it actually helps in terms of our fat absorptions and all that. So I believe that, when we talk about having pancreatic cancers, what happens is that these people, they actually have something called the pancreatic insufficiency. That means that because the normal mechanism for it to work now is jeopardized. So that's where, but to say whether having a high cholesterol, does that mean that, you have a pancreas cancer? No, not really.
Okay.
Yeah.
Thanks, Dr. Jensen. I think I like this question. Doctors, what with the recent outbreak of influenza, is it advisable for cancer patients currently undergoing treatment to be vaccinated? Maybe you can take this.
All right. I think I will give my point of view, and perhaps Dr. Jensen can share some of his as well.
Yes.
And from a primary or emergency doctor point of view, when we encounter patients who had cancer, it's quite important to distinct these two groups of patients. Are those patients still currently under chemotherapy or immunotherapy, or a cancer patient who has completed the chemotherapy treatment? In my point of view, for a patient who had completed their chemotherapy treatment, you first have to assess them first. For these are the more vulnerable group. First, of course, we ask if you have any allergy to the vaccine, influenza vaccine that's ongoing now. In the past, do you have any allergy to eggs? Because that's one of the ingredients inside the vaccine as well. Check the vital signs of the patient. If the patient is well, there is no ongoing infection, then I think perhaps this group who has lesser immune system, perhaps it would be suitable for them to take this influenza vaccine. But I do have a little bit of reservation. I think when it comes to patients who are still undergoing chemotherapy, their body is already in an immunocompromised state. And if we were to give this influenza vaccine, it's quite difficult to ascertain how every individual will react, anyone will react differently to the vaccine. So perhaps if you are still undergoing chemotherapy, that would not be recommended, but perhaps consult with the oncologist first, if you're treating oncologist. Yes.
Yeah, so I would just like to add on to what Dr. Pan says. So vaccines, in general, we say that vaccines are basically is a live attenuated, they're weakened, virus that you actually introduce in your body so that it allows the body to produce the antibodies that it helps to make your immunity strong. But the problem that as an oncologist, normally what we encounter is that while the patient is on active treatments, generally we say that your bodies are at a state of immunocompromise. That means that your immune system right now is not as strong as compared to someone that is not receiving any form of treatment. So in these situations, right, I personally, I would not actually encourage my patients to go for live vaccinations, because I know that in the event that if the patient, ended up feeling sick because after the live vaccinations and all that, then a few things are going to happen. Number one, the treatment has to be delayed. Second, we do not know whether, how severe is the condition is going to be. So some may potentially, end up having very bad fall with illness because of the vaccination. So I always look at my patients that comes to see me and ask me about vaccination, because if the patient is on treatment, I will tell them preferably not to. But if the patient is already off treatments and he has been, no evidence of disease for a while, then I would say he's well, then yeah.
Okay. Thanks for answering that question, actually, to the both of you. I think this is a question about diabetic patients. Do diabetic patients have higher risk of developing pancreatic cancer? Melissa asked this question.
Right. So so I just studies that actually they look into those with the newly diagnosed diabetes. It's not a direct cause that means that if you have diabetes, then means you have pancreatic cancers. But they, from the observations that have been done, they noticed that out of that the 100 patients, you have that one or two patients that have been diagnosed with new onset diabetes, right? It's not just about diabetes, like Dr. Pan said, and basically you need to be vigilant about other symptoms that comes along. Yeah, so all this needs to be, come together. It's like a jigsaw puzzle. You're only able to make up the picture of it if you combine all this. So the clinical acumen of the doctors is actually very important. So if you have someone that, suddenly you diagnosed with newly onset, then you have other symptoms that come along, perhaps it will be good for you to just, get health professionals to get it checked. Besides that, also diabetes itself, you also still need to be diagnosed as well. If it's truly diabetes,
Okay. Thanks a lot, Dr. Jensen. I think one question, I'll combine this from Nicole and Lisha, is how often do we need to do a medical check of the pancreas, and what is the procedure like? Do normal people go for a pancreatic check, or, how?
When we talk about screening, right, we do not screen for pancreatic cancer in particular, unless there is a high index of suspicion. Again, I have repeated that that phrase many times. If you have a first-degree relatives who have been diagnosed with pancreatic cancer, the risk predisposition is much higher. Then perhaps you have to go for counseling, check for genetic mutation, and then perhaps go for further advanced screening. But when we talk about screening, what we want is that screening that is relatively affordable, and screening that can be easily done, and a screening that can screen the masses. That means a huge number of the population at one time. without consuming too much resources.
Yeah.
So in the primary care setting or at the wellness center, most of the screening are targeted towards a generalized kind of screening. That is where the history taking of the patient, the physical examination of the patient comes in. Like Dr. Jensen say, the acumen of the doctor. If you constantly have this high index of suspicion at the back of your mind, even though if it's very vague symptoms, if we ask further, for example, oh, so you had this epigastric pain, for example. I had a patient came in the clinic, had epigastric pain. So it started long before, it started 3 months before that. So the patient had actually consulted a gastroenterologist. There was already a scope that was done. He was given medication, he felt better, but 1 or 2 months later, the vague pain came back again. So when he visited the clinic, we asked further questions. Turned out that the pain kept recurring despite treatment. So that triggered suspicion. So we actually referred him to a gastroenterologist. Further test was done, imaging was done. It was when they found out that it was a pancreatic cancer. So back to the question, screening in specifically for pancreatic cancer, no. We do check, for example, Dr. Jensen mentioned, besides your tumor markers like CA19-9 or CEA, we do check your metabolic panels as well. That means your kidney function, your liver function, because that can tell us a lot if a patient has any underlying diseases. Yes, but as Dr. Jensen mentioned earlier, some patients, they are very hooked on the CA19-9 reading.
Yeah.
Yes.
My dad.
A patient who had CA19-9 reading high for the past 6 or 7 years.
But nothing's wrong, right?
But there was nothing wrong.
Yes.
After we exhausted every investigation that we have, just so that for the peace of mind of the patient and for the peace of mind of the doctor. Yes. So it is not chronic pancreatitis. So there's a very small subset of patients who constantly have this elevated CA19-9. Yes. But let's not put our guard down. We can still perform this screening every year. Yes.
So I think the doctor's advice to you, Melissa, and also to Lisha is there is no specific screening for pancreatic cancer. But if you have a high risk or a high index of suspicion from your primary care doctor, that's when you go for further investigations. And that's actually how we detect pancreatic cancer early. For you who are tuning into the show now, you know what pancreatic cancer is about. So then you're more aware, and then you're able to then go for your further checks if there's anything, or if your relative or people around you have anything. So we hope that we've answered your question. Thank you so much to all of you for your questions. We are overwhelmed by all of your questions. We thank you for joining us and tuning in today and for sharing. Please continue to share this live with your friends, family, so they can tune in and listen in. And thank you, Dr. Jensen, for being on the show again. He's from Curie Oncology, and we have Dr. Pan, who is from Sanjal. So thank you so much to the both of them. They really answered our questions thoroughly. And we hope you've enjoyed today's session. Our next session is on 13th of March on Talking Live with Mei Sze, and we're actually going to delve further into personalized treatment and molecular testing. As what both Dr. Pan and Dr. Jensen mentioned earlier about genetic mutations and genetic testing, we're going to dive more into that. So join us on 13th of March. See you then and have a great week ahead. Bye!